Hi everyone, welcome to this episode of the REFERROLOGY series on anemia. So today's episode is special because we have three very distinguished guests with us. So first we have Dr. Kelvin Koh, who is a gastroenterologist and interventional endoscopist from NUH. We have Dr. Joanne Lee, who is a hematologist at the University Cancer Institute, Singapore. And last but not least, we have Dr. Sanmay, who's a practicing nephrologist at Ng Teng Fong General Hospital. So without a doubt, anemia is a condition that residents face very commonly in the wards. However, it's also one of those conditions where practice comes across as fairly variable and there are complexities because it's cross-disciplinary in nature. So we hope that through today's discussion, we can answer some of these questions. So perhaps just to start things off for all our three guest speakers today, maybe you could share for each of your respective specialties, what guidelines and resources would you recommend for residents to look up pertaining to anemia? Maybe Joan can start first.
So normally for anemia and for guidelines on iron deficiency and B12 or whatever, and all of those stuff, we usually use the BCSH guidelines. So it's British guidelines, but it is not just isolated or it's not the only guidelines that we use, but it's one of those ones that we will commonly quote from.
Okay. What about from the gastroenterology point of view?
Yeah, as you know, anemia isn't really the forte of gastro. We often do the scope and then we will manage the patient accordingly. But that said, I think arguably we see probably as many anemic patients as hematology because often
you probably see more.
Yeah, maybe more actually. But so I don't think there are specific guidelines with regard to anemia. But one guideline that I probably want to reference to is the small bowel bleeding guideline, probably. Because that would be one of those scenarios that are not common enough that you would see it every day, but not rare enough that you probably encounter it at least once in your clinical practice.
Okay, thank you, Dr. Koh. What about from the renal point of view?
Okay, so we use the KDIGO guidelines, which is the Kidney Disease Improving Global Outcomes Clinical Practice Guidelines. And I think the one published in 2012 is specifically on anemia in CKD population. So KDIGO is our kidney guidelines for majority of the things. And there's one specifically for anemia from 2012. So you can look at that.
Okay, thank you. So perhaps we could start with some definitions. So Joan, maybe you could take this question. You could help us with first and foremost defining anemia, whether there are gender or age-specific cutoffs, and when would anemia be significant to require further evaluation?
So typically we actually follow the WHO definition of anemia, as you can see on the slide. So it differs based on whether you're a female or male and whether or not you are old or young. And we do adult hematology. Typically we get questions about pregnant women along those lines as well. So essentially, as long as you're 15 years and above and you're non-pregnant, your hemoglobin level should be about 12 and above, below which you would be considered as being anemic. They have different categorizations of whether it's mild, moderate, or severe anemia. Pregnant women, the threshold is lower, mainly because there is dilution, there's hemodilution for pregnant women, where 11 is the threshold, and for men, it is 13. We take 13 as a cutoff for being anemic, below which it's all anemic.
Okay. What about for older patients? We don't have any differences in terms of...
No, there are no clear guidelines as to what should be considered as anemic or not anemic in the older patients. We follow the same guidelines. However, in older patients, if it doesn't really change how we manage them, or if management is more or less conservative, then actually we do not chase the numbers so much, as long as they're not symptomatic. And as a rule of thumb, anything above 10, we're quite happy in older patients. But it doesn't change your definition of anemia per se.
Got it. Okay, so maybe next we can talk a bit about iron deficiency anemia. I think in today's talk we'll focus quite a bit on that because it's relevant to the nephrology as well as the gastroenterology point of view. So perhaps first, Joan, you could take us through defining what iron deficiency is, and then we'll have a quick word by Sanmay about it from the nephrology point of view. So what is iron anemia?
So iron deficiency anemia, as the name suggests, is where iron is of course deficient. That's a slide actually showing that iron deficient, to show an iron deficiency slide, whereby you get a lot of microcytosis, you get anisopoikilocytosis where the cells, some are big, some are small. You get it being very white in that sense. So this is hypochromic as well. The markers of iron deficiency is that of a low ferritin, low iron, you get a raised total iron binding capacity, increased transferrin binding receptors, all of which help with your diagnosis of iron deficiency. But the serum ferritin is the most powerful one when you want to talk about iron deficiency in terms of definition. Our cutoff levels is 15, but only if there is no coexistent disease, because like things like chronic inflammation and like CKD, etc., can push up your ferritin levels. But if there is no such coexisting disease, then the cutoff levels should be 15 for iron deficiency.
Okay, but what about inpatient, like hospitalized patients? Because that's what residents are used to seeing. And many of them have ongoing processes and an iron is often sent off. So how do we...
Pardon, I just missed your last question. Could you repeat that again? How do we what?
Like ongoing, let's say, infection or in the inpatient setting, are there different cutoffs as to when we consider someone iron deficient?
Okay, I would say that anything 15 and below is definitive, regardless of whether or not your patient has got concurrent sepsis, etc. Below 50, then you think about whether or not this patient could have iron deficiency in addition to underlying problems. But in the case of renal dysfunction or along those lines, then some people take 100 or 200, which I think Sanmay will talk about later. Or we look at things like reticulocyte HE, which will be able to help us to tell whether a patient is functionally iron deficient. Essentially, if all of your factors, if your patient is anemic, microcytic, even though your ferritin is a little bit elevated, but you should still have a high suspicion of iron deficiency then in the inpatient setting.
Got it. Okay, so does the interpretation of the iron panel change in CKD and the definitions of iron deficiency change in CKD? Maybe Sanmay could take us through this question.
Yeah, so mainly is the ferritin level. So I think, as Joanne mentioned, the T-sets, the two things that we look at commonly looking for iron deficiency in CKD is the transferrin saturations and the ferritin level. So most of our CKD patients are in some state of inflammation, and the ESRD patients, the dialysis population, are higher state of inflammation per se, because every time they go through dialysis, there will be some sort of inflammatory process. So we use a diagnosis of iron deficiency if the T-set is less than 20% and the ferritin less than 100 in the pre-dialysis population and the PD patients. But in the hemo patients, the threshold for ferritin is higher, so it's usually around 200. So these are the two things that we normally look at.
Okay.
And in some patients, in some of the studies in the CKD hemodialysis population, they have even given iron therapy to patients with ferritin as high as 500 to 800. And they have shown that there is a benefit for iron therapy in bringing up the hemoglobin even at the kind of high ferritin levels. Okay.
And this is due to the fact that it's not just absolute iron deficiency.
Yeah, it can be a functional iron deficiency as well. So when the T-sets are low, elevated ferritin levels, is also an element of functional iron, not really just pure absolute iron deficiency.
Okay, got it. Okay, next we'll just shift gears a bit and try to frame the discussion around a case scenario. So this is Mr. A, who's a 53-year-old gentleman with background DM, likely diabetic kidney disease at stage 3 hypertension and gout. He comes in with symptoms suggestive of possible symptomatic anemia, some exertional shortness of breath and lethargy, and was found to have a HB of 6.8 with MCV that's in the borderline on admission. The last HB was quite some time back, a couple of months ago, at 9.5, hasn't been followed up very compliantly. He does not report any immediate symptoms or any other red flags such as loss of appetite, bowel habits. And he did have a scope, OGD and coronal 2 years ago, at that point in time for some loss of weight and loss of appetite, which was non-revealing. So perhaps, given that this is a CKD 4-ish patient, we could start with a renal point of view. So anyway, okay, just to backtrack a bit, today's discussion will try to frame it more from renal, gastro, and hematology point of view with some of the mentioned headings here as what we'll be discussing. So firstly, Sanmay, could you give us a brief overview of why patients with CKD become anemic?
Okay, so there is a whole load of things that can cause anemia in CKD, but most commonly it's actually still iron deficiency anemia. And if you do find iron deficiency anemia, then you need to look for why the patient is iron deficient. Are they just nutritionally iron deficient, or are they bleeding from somewhere? Do they need scopes? I mean, they are still same general evaluation as some in other patients, but they also do have an element of functional iron deficiency because of high hepcidin levels. So these patients also have that element of functional iron deficiency. Then in terms of erythropoietin, as your CKD progresses, your erythropoietin levels also generally reduces, and not just that, but also they get more resistant to erythropoietin, and not just a reduction in the production of EPO. So then you have anemia of chronic disease, which is related to the underlying inflammatory state. This can also affect the bone marrow's responsiveness to EPO therapy. You have your B12 folate deficiencies like in a normal person. In your ESRD cohort on hemodialysis, blood loss is actually a big thing causing a hemodialysis, a HB drop. So for example, if patients are on heparin-free dialysis for some reasons, they are prone to bleeding, and if the circuit clots, that can lead to a 250 ml of blood loss straight away. So that's also a major cause of blood loss. Reduced RBC survival and bone marrow suppression by uremia. These are one of the listed causes, but it's not something that we see very, very commonly.
Thank you. So when does CKD, or rather when does anemia become a problem? Because CKD, we know it ranges from 1 to 5.
So actually you can see from this graph that from stage 1 CKD, this study from America, a large cohort of patients, but essentially from stage 1 CKD, you already have some patients with a bit of anemia, but it generally only becomes a significant problem once you hit stage 4 to 5. When your GFR hits less than 30, that's when we see more significant anemia that needs treatment. If you have severe anemia, less than 8, as Joanne said, you will have disabling symptoms in your patients, your elderly will be very frail, their quality of life affected. Also, it is independently shown to cause progression of LVH and heart failure and adverse cardiovascular outcomes and mortality. So if there is anemia, we need to pick it up early and treat it, which is why once the patient hits GFR of less than 30, we do ask the polyclinic to refer us early, so that anemia is one of the things that we can start managing early on as well.
Okay. The next question is something that I think residents may struggle a bit on, because many of these patients do have anemia, and I guess oftentimes they are being managed with either some form of iron, or in the ESRF patients, EPO. So when is it that we have to look beyond the CKD for anemia? I guess there isn't a simple answer, but how do you all generally approach it to say that this is due to the CKD, or when is it less likely due to the CKD?
So I think to approach anemia and CKD population, you have to approach it similarly to a general population. You need to look for your causes of anemia. So we will screen all the nutritional deficiencies, B12 folate, iron. Then if there is iron deficiency, generally we do counsel our patients that we would recommend refer to the gastroenterologist to consider scopes. And only if the patients refuse for whatever reason, they don't feel that it's necessary, they understand the risk of missing malignancy, then we will treat with iron therapy if they're iron deficient and see if they respond. If they're iron replete, then less likely it's going to be a GI problem. Then in that case, we may decide to start erythropoietin and see whether they respond to it.
Okay, thank you. So for the next question, I guess it's a lot of details, but maybe you could just give us a quick overview in terms of optimizing iron and EPO status in CKD and I guess ESRF patients. What are the key principles, as well as the medications, threshold targets, and how do we anticipate patients to respond to the treatment?
Okay, so it's a bit busy slide. It's split into a non-dialysis cohort of patients and dialysis, because the lab values that we look at differ as well. So generally, most CKD patients, this is a non-dialysis CKD cohort. Once the T-sets are found to be less than 30, we do start oral therapy just to see whether their hemoglobin will respond to it. I mean, if they're anemic with the iron set of less than 30, then definitely we will be giving some oral iron. So in terms of oral versus IV iron, I think Joanne will talk about it later as well, but because they're not on dialysis, and oral iron is just the easier way to give supplements. So we do start with oral iron therapy. There's some select group of patients that we may admit for IV pharyngeal. If they don't tolerate the oral iron, they have a lot of side effects. They have severe anemia, which we want to bring up the hemoglobin a bit faster, avoid blood transfusions. Then we may choose to admit them for a day procedure to give them some iron therapy. So in terms of the iron that we give, there's two options that we normally choose between. One is iron sucrose, which is Venover. The other one is ferric carboxy maltose, which is Ferinject. We will give Ferinject in patients are not on dialysis, just because the total loading dose of Ferinject that you can give is higher at one go. So it avoids the many admissions that you need to give the same dose. So Ferinject you can give 1 gram. So obviously you need to monitor them for risk of allergic reaction and things, so they will need a day admission. So after giving the iron therapy, then you need to reassess them in probably about a month's time, check their iron status again, check their hemoglobin. If their iron levels have improved, their ferritin T-cell levels have improved, then if they're still anemic with a HP less than 10, then we would then choose to start them on some erythropoietin. So what sort of, when do we initiate the EPO? So firstly, you must make sure that they are iron replete, because if they're not iron replete, then if you start the EPO, they may not respond to it. So then it's useless. If they're iron replete, then we will start erythropoietin. There's a few options, which I think I've written in the next slide. Short acting, medium acting, long acting. The most common ones that we will see are the short acting ones, because it's the cheapest. So Recomon can be given subcutaneous or IV. So we give this in our dialysis cohort of patients. For CKD patients not on dialysis, if you want to give a longer acting medication that will increase compliance, so they don't have to inject it every 1 to 2 times a week, they can do it every 2 weekly or monthly, then we can choose to give dabigatran or Mircera, but these medications are more expensive. So going back to the aims of therapy, we aimed for a hemoglobin of 10 to 11.5. We try not to hit a hemoglobin of above 12, because the studies have shown that there's increased risk of strokes, malignancy, and venous thromboembolism in patients with a hemoglobin above 12 in the ESRF cohort. So we have to adjust it accordingly. Once it starts hitting above 12, we need to cut it down. Recomon dose, which is the most common one that we give, dosing is about 50 to 100 units per kg per week. You monitor 2 weeks later, 2 weeks to 1 month later, and then you adjust it accordingly. Okay, then the next slide is the difference between PD and HD patients. So iron targets for the hemodialysis, the ESRD cohort is higher. So our guidelines actually say we aim for a T-cell of more than 30% and a ferritin of more than 500. So if they are not at this target, we do start them on iron therapy. In the PD cohort, actually the ESRD patients don't do very well with oral iron. For some reason, the GI absorption is lesser. They don't respond very well. But because PD patients don't have a venous access, so we do start them on oral first, but there's a higher threshold of, lower threshold of admitting them for IV iron if they don't respond to the oral iron therapy. Again, the aims are the same, 10 to 15, 11.5. Hemo patients are easier to treat with iron because of the venous access. So we will treat with Venover loading dose, which is 100 milligrams once a week for 8 to 10 weeks. And then we keep them on a maintenance dosing of 100 milligrams once a month, just stopping any oral iron therapy because it just, the GI absorption is very poor. And anyway, they have so many medications to just help to, for them to be more compliant to it. So as I mentioned, we aim for 10 to 11.5, mainly because of the side effects of the, one is the side effects of erythropoietin. Erythropoietin has been known to worsen malignancy, especially RCC, which is fairly common in the ESKD population. Secondly is if they have high BP, it can actually precipitate strokes in some patients because it can increase your blood pressure for them. So you you need to see their comorbidities, whether or not the one issue is also patients with recurrent venous access thrombosis, like their fistula always clots. These patients may be more prone to getting clots. So really, these patients, you must try and keep their HB below 12 and try not to aim hemoglobin too high. We monitor the hemoglobin every about 2 months or so on dialysis and then adjust it accordingly. IV iron needs to be held off during active infection. So when patients are admitted to the hospital on ESRD patients for infection, the venofer will generally be held off until they complete their antibiotics.
Okay, thanks a lot, Sanmay. Okay, next we'll probably shift gears a little. Dr. Calvin, mind sharing a bit about what your thresholds are in terms of endoscopic evaluation, the presence of iron deficiency anemia? So I guess practically some patients may appear to have a very strong dietary component of things. Currently, we are seeing foreigners coming in with iron deficient and perhaps nutritionally they're not replete. Do these patients need to be scoped? How do you make this decision?
Actually, I think the first question would be probably what sort of pathologies we're expecting, and then again, I think like mentioned, there's nothing like a history and pre-test probabilities or what the conditions you think you're looking for. To be honest, nutritional deficiencies in Singapore are exceedingly rare. I see them, of course, but not very often. Usually, it's like you said, maybe in the foreign population, but then in the foreign population who is young, you have to think about whether they have an ongoing like a parasitic infection or something like that that predisposes them to be iron deficient. Even unless they are completely vegan, and then the deficiency anemia you get will be probably B12 deficiency rather than iron. So in some textbooks you may read about some like South Asian ladies who are very elderly drink tea and all that, and as a result iron deficiency anemia. In real life, I've found that to be exceedingly rare as well. So I think the bottom line is that iron deficiency in males and postmenopausal females, basically you have to consider malignancy as one of the more serious conditions, which is why we almost scope everybody that is referred to us and agrees for a scope. Okay. Yeah, and then I think there's some evidence behind this. This is a cohort, population-based cohort, looking at referrals in the NHS, and basically what they did was they basically they look at the odds ratio for cancer, and you can see basically as your hemoglobin goes down, your odds ratio for cancer goes up from 2.5 for males at a hemoglobin of 12 to about 27 compared to control when hemoglobin is less than 9. Even microcytosis was associated with increased, just pure microcytosis without actually anemia, which probably reflects mild anemia or mild iron deficiency. Pardon me, and then so basically, I think iron deficiency is generally not to be taken lightly. We probably want to evaluate it if the patient is okay.
Okay.
Right. Yeah, I think the other point is that iron studies may vary from point to point. I think this is something that probably Joanne would also concur with, because you can see that this is actually an interesting study looking at patients who are screened for hemochromatosis. So basically they had a random sample, they just took some blood and then they ran it for transferrin saturation in this case. And then the patient came for a proper test and then the fasted sample. And you can see, even though generally there's concordance along the way, you can see there's a wide variation. Sometimes patients had almost like a near 100% iron saturation, but somehow when they turn up fasting, they were like near 0. But again, this is just a random box plot just to show you what sort of ranges there can be. And of course, the other point is that often the patients in the wards are kind of fasted for various reasons. Either they came in infection, pneumonia, cannot eat, or swollen dysfunction, acute stroke, cannot eat, or whatever reason, or planning to refer gastro, also cannot eat. And so by the time they actually have an iron test done, it's probably like a few days down the road where they've been fasted. Although that said, the data for fasting and iron depletion is not so strong for acute fasting. We don't really have very strong data, but I mean, it's something to bear in mind, maybe. But if it's most of the time, is the iron deficiency is not really in question. It's quite obvious. Yeah, but this is just another point to consider. Yeah.
Perhaps in terms of your practice, for let's say the milder anemias, would it be better to do the iron panel outpatient rather than when there's so many things going on? What would your recommendation maybe for?
Yeah, that's a very good question. I think, of course, we know that the best time to evaluate many of these patients in the ideal setting is outpatient. However, I do think there's a role still for opportunistic evaluation, because some of these patients never make it to outpatient, or if, for example, if you have like a cancer or something, you probably don't want to wait for the outpatient review, which in our setting sometimes can be a couple of months, depending on how urgent the appointment was made and all that. So I would say that it might be an opportunity to send it off, even though without these caveats. Yeah, for example, most of the time, like I mentioned, the patient comes in with infection, and then the ferritin would most likely be high. So you never almost hit an iron ferritin of less than 15 usually in the inpatient setting under medicine, maybe under hematology, but usually rarely under medicine. Yeah.
Joan, what's your take on this?
Well, what he says is right, meaning that actually actually all of these transferrin levels and all of that, they do actually change with when you take it. But I think as it goes, if it is less than 15, you can say there's definite there is iron deficiency. If it is more than 15, it doesn't mean that it's excluded, because there are other precluding factors that could play a role. So I think it depends also on your what you're looking for and what your suspicion is at that point in time. I don't think we should give a particular cut off in that sense. Even for the renal patients of 100 and 200, their cutoff is also in patients who are otherwise well with no other infection on board, you see. So it's a bit hard to say that there should be a cutoff to below which you yeah.
Okay. Check. So practically, if it's like not very sure and we want to repeat it, let's say after an acute infection or illness, how long later should we do it in the outpatient setting if such a situation arises?
Oh, then it depends, because it also depends on what your infection is and all of that. But as a rule of thumb, as long as your patient is clinically better and not on ongoing antibiotics and stuff, give it a while for him to settle, then you can check it again. That is, of course, having to say, I mean, you probably assume that your patient has no other reason to have some sort of chronic inflammation, then you can check it again. There is no hard and fast rule and no guidelines as to determine what is a good amount of time to wait. But I would say the longer you wait from the acute infection, the more likely you're going to get more accurate reflection of your ferritin levels.
Thank you. Okay, so the next question that residents sometimes have is like, hey, this patient had a recent scope and like this anemia has been like festering for a while or maybe getting a bit worse. So this concept of validity is sometimes called into question. So Dr. Kelvin, what are your thoughts on this?
Yeah, so the question is, how long are scopes valid for? And I think the main point is that endoscopy reports, unlike passports, they don't expire. So they don't have a validity duration, 5 years and then okay. But I think the bigger question, which I think is in the next slide, is there a role for repeat scopes? And I think this ultimately boils down to what you are looking for, what sort of conditions you're thinking about. For example, generally gastroscopes, I would tend to repeat them more often because about, let's say, a month ago was okay, but a month later may have an ulcer, things like that. So peptic ulcer disease and all that can come on and of course can come on quite in a relatively short time. Whereas if you're talking about the colonic dysplasia from normal to cancer, typically in current thinking takes about more than 10 years. So if you're thinking about cancer, probably you want to think again, especially if you had a reasonably good recent scope. So the boils down to the point number 2, which is what are your differentials, whether it's peptic ulcer disease, GAVE, which is also quite common in renal patients, colon cancer, gastric cancer, acute colitis, and inflammatory bowel disease, usually in decreasing prevalence. Of course, acute colitis can happen, but apart from that, if you're worried about cancer, usually a recent scope in the last couple of years makes a cancer test reasonably less likely. So we have to basically take a history, find out what the pre-test probabilities are for each of these differentials. For example, if this patient had 100 polyps and then every 2 years all his family members died last year from colon cancer, then maybe it might be worth repeating the colonoscope, despite what I'm saying. But ultimately, it depends on how to individualize these risks to the patient. So the other part that we often don't quite mention is what the risks, benefits of investigation, including the endoscopic risks. So some of these patients are also moderate to high risk for some major adverse cardiac events from moderate sedation. Some of them are at risk for contrast nephropathy if you give cross-sectional imaging. And then so we'll discuss carefully with the patient what is the aim. Basically, we'll say, no, look, we probably need a scope. And if they don't want a scope, say, okay, maybe how about at least a scan? And then if you don't want a scan, then we are really kind of stuck. So, but ultimately, the scan is not the most ideal for evaluation of anemia, as a flat lesion, small lesions, even ulcers cannot be seen very well with a scan. So really, we are talking about endoscopy if possible, and if the patient can tolerate. That said, if the patient is like a very frail, not really fit for a haircut, then maybe it's not such a good idea to do a scope. Yeah, so it's all about, there's no direct algorithmic medicine for this. It's probably looking at the patient, figuring out what's the most likely differentials for him or her, and then discussing with them and maybe the relatives what is the next best approach or what's the best test for the patient in this case.
For the upper GI malignancies, because you mentioned for colonic, normally it can take up to like 10 years to develop. Is the time shorter for upper GI malignancies?
That's a very good question. The bigger question actually is whether or not there's a background of intestinal metaplasia. If there's a background of intestinal metaplasia, that puts you at increased risk, up to about 6 times the baseline risk for gastric cancer. Our baseline incidence of gastric cancer locally is actually not as spectacular as the Chinese, Koreans, or Japanese. But that said, we do have some. But the easier question to answer is that because peptic ulcer disease is also not that uncommon, we often, the threshold for upper endoscopy is quite low. So even though we think gastric cancer is not so likely, we can still offer to do a scope because it could be just a plain old ulcer, which given our prevalence of Helicobacter in this region and all that, and it's not so, and aging population per blood supply, of that is not unreasonable to find. In fact, many of our patients, after doing through this and that, eventually it's a peptic ulcer disease.
Got it.
Calvin, can I ask you something? Some of my patients will come to clinic when I counsel them for referral to gastro for scopes and say, Polyclinic has done my stool twice and I haven't found any blood. I don't want to go. So what should I say to them?
So I think this is a bit of going to the utility FOBT for screening occult.
Okay.
Which I mean, okay, I think I have a few slides on that. We can go through that maybe first. So as you know, FOBT, as everyone knows, is indicated best as a screening test for asymptomatic average risk colon cancer. Utility outside this remains unclear. So in a Swedish study, about 4.5% of the colon cancers were negative for FIT. And then inpatient practice suggests that about a quarter of them actually had waiting for FOBTs eventually, which kind of delayed the overall investigations. That said, ultimately, like many investigations, it is a give and take. So FIT is supposed to be 90% accurate or sensitive for colon cancer. And so generally, if you have 2 negative FITs, the chance of frank colon cancer is low, but not zero. That's it, number one. And if the patient, actually the next slide is probably quite important as well. The next slide maybe. Yeah, so I think it's an armamentarium. So it's one of those things that we do. I wouldn't recommend it as first line or second line or third line, but if the patients really don't want to do anything, then we have to really think about whether they can be convinced or something. Sometimes the FIT can convince them to do the scope itself. It means it's positive, okay, then they can do the scope. That's probably what the polyclinic is hoping for. But for patients that are frail and not going to be subjected to endoscopic evaluation, then FOBT leads to like a Mexican standoff, right? So they'll say, oh, you can do the scope, but oh, you will die, or maybe you can do the scope, then you can get cancer, but anyway, you get cancer, so you'll still die. And so then the patient becomes very upset, and with both us and the polyclinic or whoever it is. And so basically patients that probably not suitable for endoscopic evaluation, maybe not the best thing to do. But that said, these patients are generally not so common, but vast majority of patients probably are reasonable to subject to endoscopic evaluation if they are agreeable to. Yeah, and FIT or FOBT in this case is probably one of those things that we can have in our armamentarium to kind of deal with some of these patients, but it's really not the best test. If you want to investigate it properly, it would probably be a scope. Alternative, which is not the recommended alternative, but an alternative might be a CT colonal. And the alternative to that would be going down the food chain would be a colonoscopy, a regular CT scan, sorry. And then if that's not possible, then some people just do an FOBT. Yeah, so I think that generally in that order, but usually it's not the best test, I would say.
Lower GI bleeding, or even for upper GI bleeding, it can cause FOBT to be positive?
So generally, the current tests are much more specific for lower GI bleeding. Actually, if we talk about FOBT, there are generally 2 groups of tests. Actually, fecal occult blood test is the full name, right? But actually, there's 2 tests. The older guaiac test, basically they use a chemical test to look for the reducing property of the heme group. which of course can be altered by many things, including red meat, vitamin C, broccoli, and all sorts of things that people used to have to abstain for before going for the guaiac test. But nowadays, most labs will do a fecal immunohistochemical test, which basically detects the intact human hemoglobin, the heme ring, basically. So that is relatively specific for blood. And the upside to this is that actually it's quite specific for lower. Improves the sensitivity for lower GI bleeding, but it kind of reduces the sensitivity for upper GI bleeding. In the old days, if you had a peptic ulcer disease, your guaiac test would have a higher chance of picking it up. But with the FIT, most of the hemoglobin generally tends to be digested. So you actually have a slightly lower sensitivity of for the modern fecal immunochemical tests.
Okay. But
as a side point, you won't really be doing a FOBT for upper GI generally.
Okay, we could backtrack a bit to the question on small bowel evaluation. So sometimes patients with iron deficiency, they have upscopes, downscopes, can't find anything. The next question is there a role for small bowel evaluation? So could you weigh in on this, Dr. Koh?
Yeah, so I think as Sanmay has mentioned, there are many reasons for patients, particularly renal patients, to be anemic, and oftentimes it is not necessarily small bowel bleeding. Like even things like innocuous, like for example, like commonly mentioned, the circuit clots are quite common, and sometimes if you kind of dig deeper into the dialysis notes or whatever, which often we may not have at the clinic, but we try, and then you may actually notice that actually there have been clotting, they have a lot of fistula access problems, and then that probably is the more common reason. So, but small bowel bleeding, so generally is uncommon. It's about 10%, 5 to 10% of all GI bleeding, assuming that the patient is actually bleeding from the GI. And the recommendations are a few, of which I will just highlight 3 points. First is that before we proceed to blaming the small bowel, we generally want to check again the up and maybe even the down scope before small bowel evaluation. Sometimes a second look examination may reveal, for example, an ulcer that was behind a fold, or a large colonic mass or polyp or all that, and that will save you the small bowel evaluation. By and large, most people nowadays would proceed on to a video capsule endoscopy because it's relatively non-invasive. The main challenge is that it is mainly purely diagnostic, and then it may pick up very non-specific findings. For example, you may find out some red spots somewhere in the mid-jejunum. What does that mean? Does it mean that the patients need to be subjected to a push enteroscopy, a spiral enteroscopy, or a single balloon? And all these are relatively invasive and not so pleasant options. But by and large, I think the video capsule endoscopy would be a useful first evaluation if you were to consider small bowel bleeding as a significant differential. And but before we do the video capsule endoscopy, we usually, or at least I in my practice, usually like to get an imaging first, at least a CT scan or something, to make sure there's no like large gist or something that you're not missing, which you may not pick up on the gastroscope or the colonoscope, and or stricturing disease, which will mean your capsule will be stuck there forever, which is not a good idea because, as you can see from the photo, there are button batteries inside, and eventually they do break down. So you don't really want the capsule to get stuck. Which happens with the risk we quote is about 0.5 to 2%. Yeah.
So what are your types of patients who usually end up with small bowel evaluation?
So generally the yield for small bowel, actually you'll see the literature suggests that the yield is actually best if there's overt GI bleeding. That means if you see melena, but the gastroscope is negative and the colonoscope is negative, and then there's active ongoing GI bleeding, that's the best yield, because then you actually have a high chance of picking it up. A lot of times, this, for example, if you think about it, other common causes besides the rare angiodysplasia would be things like things like NSAID ulcerations, and NSAID ulcerations also tend to heal. You see, so often by the time you get to the capsule endoscopy, the is not revealing. Then you never really have a diagnosis, and a lot of patients are actually like that. So I'd say probably only about 10, depending on the pretest probability and how you do it, probably about 10 to 15% you may actually see something that's helpful. But the vast majority, often we may not necessarily find something useful. Or we might find something equivocal, then we have a further discussion, but the hemoglobin usually stabilizes at that time, and the patient usually is not keen for very invasive investigation.
Okay. All right, so next we'll move on to the hematology segment. So John, so this is, I guess, a very up the front question that residents sometimes have. Like this patient comes in with anemia, and maybe micro or macrocytic. So the question is, do we then test for everything? So usual people say anemia screen, B12, folate, iron, thyroid screen, all that at the same time, or should it be targeted based on the MCV as a first cut?
I think it depends on what you're looking for. We generally go based on targeted treatment based on your MCV. But if a patient is microcytic but have other signs and symptoms suggestive of hypothyroidism, it doesn't necessarily mean you don't check the thyroid. But for whatever, in general, we would actually do targeted testing based on the MCV just because it is more cost efficient, and the chances of you finding something would be more likely if you based on the MCV. Yeah.
The next question is, has someone been alluded to earlier? Some patients just incidentally note macrocytosis or microcytosis with no actual anemia. Do these patients then, for the microcytosis group, require evaluation for iron deficiency, and for the macrocytosis group, require further evaluation for like B12 folate, hypothyroidism, i.e. which happens first, the anemia or the changes in the MCV for the red blood cell?
So usually the MCV actually changes first before the anemia is actually becomes a problem. So like what Kelvin was saying, what Dr. Ko was saying just now, microcytosis wise, you actually do get the microcytosis before you do get the actual anemia, because the amount of hemoglobin per cell actually reduces first before you get the absolute drop in the amount of hemoglobin in that sense. So actually, you will get the changes first before you get the anemia, but patients actually don't feel anything until they get the anemia. So in terms of evaluation, yes, we would evaluate even if there is no actual anemia to pick up early symptoms. But having said that, macrocytosis does not always equate to B12 and folate deficiency, and the same thing, microcytosis does not always equate to iron deficiency. So you need to look at your causes, and besides evaluating for these nutritional problems, you need to look at for other causes as well.
Okay, sure. Perhaps what other common causes should residents be thinking of in the context of micro and macrocytosis?
I mean, so like macrocytosis, the two commonest causes, iron deficiency and of course thalassemia. Those are the two big ones which you probably should look for. For macrocytosis, it's B12, there's folate, there's hypothyroidism, liver disease, what else? Things like myelodysplastic syndrome, myeloma, etc. That can also account for the macrocytosis. So we will evaluate all of that as well.
Okay. The next question is about interpreting the reticulocyte profile. I think some residents find it a bit confusing because there are multiple parameters on the reticulocyte profile. Could you take us through what is entailed in it?
So like the reticulocyte profile actually comes with three things. One is reticulocytes, one is reticulocytes AB, and one is reticulocyte HE. So reticulocyte actually looks at the percentage of the total red blood cells. So it is reported as a percentage. For example, it's 2.27% or 2.3%, something like that. And it fluctuates actually based on the amount of red blood cells present. So a higher percentage the amount of reticulocytes will be represented as a higher percentage if your patient has anemia as compared to a patient not having anemia, even though the two patients have exactly the same amount of reticulocytes in that sense. So it's a percentage essentially. Reticulocyte AB means absolute amount of reticulocytes. It is calculated the numbers times 10 to the power of 9 per liters. We like this as a hematologist. We look at this because we see whether or not these patients have reticulocytes and in relation to his hemoglobin. So for example, if a patient has a reticulocyte absolute count of 120 with a hemoglobin of 10 or 11, that to us is more or less appropriate response. But if you have a same reticulocyte absolute count of 120 with a hemoglobin of 4, then that's inappropriate. Even though a reticulocyte absolute of 120 is still high, it is still not sufficient for somebody with a hemoglobin of 4. So there has to be something else in the background that is resulting in the patient not being able to mount the same response. Could either be the patient also has nutritional deficiencies, or the patient also has some sort of bone marrow disorder, preventing this patient from producing an increased response to the anemia. And then the last one is reticulocyte HE. This actually measures the amount of hemoglobin in reticulocyte. It indirectly measures the iron stores within red blood cells, and it's used to check for functional iron deficiency. I think Reno likes this, or rather we think they do. Do you, Sanmay? Do you guys use
I
this?
don't use it very much, really.
Okay. We in our guidelines, some guidelines will say cutoff of 29 or something like that to get a functional iron deficiency to measure. But we look at the reticulocyte absolute count.
John, a bit more on the absolute count. So how can residents eyeball or gauge whether or not the relative to the hemoglobin is an appropriate response? Is there a formula? Is there a way to sort of gauge?
So as a ballpark figure, in general, the upper limit of normal, I believe, is somewhere between 95 to 100, around there, for absolute amount of reticulocytes. So if you're within the normal range, then generally your hemoglobin should also be normal in that sense. There is, if you want to talk about a higher, somewhere within with a hemoglobin of 10, I would expect a reticulocyte count of maybe roughly about 150. If the hemoglobin is anything less than 8 or 7, you would expect the reticulocytes to be way higher at about maybe 150 to 200. But having said that, this also depends on the rate at which you are losing hemoglobin. If you are hemolyzing, and it's more like if it's a hemolyzing, and it's like the patient has lost blood over maybe the past couple of days to weeks, your body is able to mount the response. But if it's an acute blood loss, for example, your hemoglobin is 5 now, but your patient just went from a 14 to a 5 within the past 1 day, you're not going to see this reticulocyte response yet. So it's not just the absolute amount of hemoglobin, but it's also the rate at which you lost it. You lost the hemoglobin in that sense, because basically your bone marrow can't respond so fast either.
Okay. And do all the hematinic deficiencies, iron, B12, folate, cause a reduction in the reticulocyte response?
Yes, it all should. So basically, you don't have the raw materials in order to build red blood cells. So you're not going to get these baby red blood cells coming out as well. But having said that, the moment you replace the iron, you replace the B12, actually, these patients actually do get a very good and brisk retic response. And the main reason why is because their bone marrows are not problematic. It's just because they don't have enough of the raw materials to build on it. So within a couple of days, even, for example, pernicious anemia, you give them iron B12, within 2 to 3 days, you should see a rapid retic response already.
Okay, thank you. Just a quick question on blood transfusion. What are transfusion thresholds and transfusion targets in general?
Oh, okay. So basically, they've done a few studies, for example, in ICU patients where they look at higher threshold versus a lower threshold, and actually they found that the patients with a lower threshold, hemoglobin more than 7, actually they did better than those with a higher thresholds. But in general, what we aim for is a hemoglobin target of about 7, unless your patient has IHD, ischemic heart disease, has got active bleeding, strokes. Then we aim for a transfusion target of about 8. For PCT, this is about for PCT. For platelets, we aim for a transfusion target of more than 20, unless your patient is acutely 20 if your patient is septic or has fever. Otherwise, actually 10. We just go for 10 actually. So like for example, our chemotherapy patients in the outpatient setting, if they're otherwise well but have thrombocytopenia due to chemotherapy, but not septic, not bleeding, etc., we keep their platelets above 10. If they have a fever, or unwell, or for example, a general medicine patient who has, for some reason, has thrombocytopenia and has fever, we keep the platelet above 20. If your patients are bleeding, for example, in gastro, and have active PR bleeding, etc., we keep it more than above 50 to 100, depending on how massive the bleeding is.
Okay, thank you. Okay, so I think Sanmay talked a bit about this, and I think Dr. Kelvin also weighed in a little. Maybe we can just talk about the types and choice of iron replacement. So perhaps you could take us through what are the types of oral formulations there are, NUH and in Unting form. What's the content of iron, and maybe Dr. Kelvin can share about your experience of the GI side effect profile, whether there's any differences amongst these formulations.
Okay, so I think there's a slide on this.
Yeah, let me go to the back.
Here. Oh, okay, dosing output. Yeah, so basically the ways to replete iron, there are a few ways. One is diet. You can get it from actually heme iron or non-heme iron, mainly for those people who are vegetarian. They can eat dark green leafy vegetables, dried fruits, etc. Oral iron-wise, normally we would say that in order to replete your iron stores, you need to take ferrous sulfate at about 325 to 650 milligrams a day. But normally we calculate based on elemental iron because ferrous sulfate may not be that readily available. And vitamin C actually enhances the iron absorption. In NUH, and I suspect it's the same in Untitled as well, we don't have ferrous fumarate and ferrous sulfate anymore. What we have though is sangobion, which is essentially it's a mix of iron, manganese, copper, ascorbic acid, folic acid, cyanocobalamin, quite a few things actually. Sangobion though only contains about 30 milligrams of elemental iron per tablet. So technically, if you wanted to replace your iron stores, you would have had to take about 3 to 4 tablets minimum a day actually in order to replace the iron stores. So like what Sanmay was saying earlier, the other alternative would be the polymaltose tablets or the polymaltose drops, which actually has a lot more elemental iron, and that is what's available over here.
Okay.
That's our
For
first
the
line now
polymaltose,
with our patients.
what is it?
Maltopher is our first line iron option.
Maltopher. It's the same.
Yeah.
Polymaltose is maltopher.
Yeah.
Yeah.
And normally your dosing, how do you dose it for the polymaltose, the maltopher? The frequency.
So we start with 100 milligrams, which is the once a day. So I guess down here, Joanne is saying that we need to replace 100 to 200 elemental iron, right? So we generally start with 100 milligram, make sure they don't have too much side effects from it, the GI side effects, and then we can push it up to 100 BD, 200 a day if they tolerate well.
Okay. Dr. Kelvin, in terms of the side effect profile from the GI point of view, is there significant difference based on your experience?
Usually, I think the most common side effect that I encounter is constipation. But that's the most common side effect that patients complain to me. Yeah, so I think often if you give it, you may want to consider prescribing a bit of lactose or something like that at the same time, so to kind of mitigate this, to improve compliance. Because if they're constipated, they find they don't want to take it. If they say it's too heaty, and then that's it, they stop taking it.
Is there a difference between the different preparations, or they all give a similar?
I think they all generally do, and I guess it's related also to the iron content. So if you have a more potent preparation, you may potentially have more. Though I don't have that much experience with the polymaltose, to be honest. But constipation is a real problem, and it's something that we try to proactively deal with when we prescribe it.
Yep.
I think anecdotally, some of my patients have told me that they prefer the drops because it doesn't cause so much GI side effects. But we don't really have, if they don't tolerate, I do try and see to change the drops and see whether they tolerate it. If not, then they need IV iron. So we try.
Do you routinely prescribe vitamin C iron supplementation?
I don't. It can cause renal stones, so I don't.
All right. Okay. In terms of, so parenteral iron, when do we need this? And how do we decide between the preparations? I think Sanmay mentioned a little, but Joan, do you like to weigh in on this?
Yeah, I think Sanmay actually mentioned quite a lot actually about this part. So the same thing for CKD patients unable to tolerate oral iron, supplemental iron not enough, significant blood loss, you need to raise the hemoglobin very quickly, preoperative patients whom you don't want to give blood transfusion to, who are iron deficient. So all of that are ways why, are kind of like reasons why we would give parenteral iron instead. There are 3 different iron parenteral iron available for us in NUH itself. There's the FOBT, there is a Venofer, and there's Ferinject. FOBT can be given as an IM injection. But if I'm not wrong, studies have not been done in the pediatric population. So FOBT is only meant for the adults. It's iron polymaltose basically in the IM or the IV formulation. There's Venofer, which like what Sanmay was talking about, they tend to give that a little bit more in the renal patients, but not as a loading dose because it takes a long time actually to load up. And you can't give so much at one go. It lets iron sucrose. Ferinject, we tend to give more Ferinject in the outpatient setting because our patients are generally not CKD and generally they want that quick boost. And if you're talking about preoperative as well, the loading amount of iron loading that you can give to the patients are a lot higher. So we tend to prefer Pharynject in that sense because you can give them a lot more in the quicker span of time.
Okay.
Yeah, but in terms of the side effect profile, there is always going to be a risk of anaphylaxis with any formulation.
Okay, thank you. So maybe we'll talk a bit about B12 and maybe a bit of folate deficiency. So the questions would be, what are the cutoff definitions? Is there any role to check methylmalonic acid or homocysteine in the gray zone areas? Should we be screening for pernicious anemia given that management nowadays with high dose oral replacement may suffice from that point of view? And IM versus oral, when to recheck? And the last question would also probably be relevant from the gastro point of view in terms of guidelines for pernicious anemia scope screening. So maybe Joan could take us through the initial bit about cutoffs.
Okay, so this is a slide on like B12 deficiency. And yeah, this one's just basically a peripheral blood film where you can see like a hyperlobated neutrophil. That's typically what we see. There is some macrocytosis, and in severe cases of B12 deficiency, there is anisopoikilo, whereby the cells, some are big, some are small, etc. Okay, so this is what we use. This is actually from one of our BCH's guidelines to determine when to do. This is to answer your question about whether or not we check things like MMA along those lines and the homocysteine. So essentially, if the patient has a strong suspicion of cobalamin deficiency with objective parameters, like for example, they're anemic, they have glossitis, paresthesia, etc. If the serum cobalamin is less than 200, then we say that it's actually probable deficiency. We then go on to check the intrinsic factor antibody and start treatment with cobalamin. If the intrinsic factor is positive, we label them as pernicious anemia and we treat them with IM injections lifelong. If they're negative and if clinical response is present, it's likely that they have this antibody negative pernicious anemia, because patients who have, there are some patients with pernicious anemia who actually are negative, antibody negative. So it all depends on the clinical suspicion and what we think at that point in time. For those though that are kind of like in those who actually have a serum cobalamin that is actually normal within the reference range, but we still think that there could be some sort of a cobalamin deficiency, then we do check the anti-intrinsic factor. And this is the BCSH guidelines where they do check MMA and homocysteine levels as well. If they have other blood tests which actually are suggestive of B12 deficiency, then they would go on and treat them as for pernicious anemia. But if everything else is negative in that sense, then actually they would actually consider stopping therapy subsequently if we are not suspicious actually of any further B12 deficiency. Practically though, in Singapore, we don't do these tests, mainly because it's very costly. Firstly, some of the tests are not available. We have to routinely send out these tests actually for them to be checked. So I think as a rule of thumb, if we think these patients are most likely pernicious anemia based on their history, based on their B12 levels, and based on how they present, even if their intrinsic factor is negative, we would still treat them as if they have pernicious anemia without checking all of these levels and just treat them with IM B12. Anyway, the treatment is quite harmless in that sense. It's just B12 injections or high doses of B12 in that sense.
Okay. A segue to what you just mentioned is high doses of oral B12 and IM B12 equivalent in terms of, because I think UpToDate does say that you have the option of giving super therapeutic doses of oral B12, and whether they're pernicious or not, that should still enable them to have adequate absorption. Is that the case?
Okay, I think as a general rule, you don't use oral B12 to replace a patient who has pernicious anemia and who is anemic at the beginning, because these patients are already very severely B12 deficient. You need to build up their stores. And you know, even if let's say I turn vegan today and I don't take anything with B12, technically my B12 stores within my body is sufficient to last me for 2 years. So you can imagine these people with B12 deficiency who have pernicious anemia, who, for example, have pancytopenia and all of that. Yeah. They are actually more than 2 years or at least 2 years deficient of B12 already. So having said that, and a high supratherapeutic dose of B12 is not going to help them to rebuild their stores. So what we do is that we would definitely give them IM first to completely replenish all their stores. And then later, if they are no more anemic, no more macrocytic, adequate stores, etc., to maintain them, you can give them supratherapeutic doses of B12. Having said that, you probably want, if a patient has been proven pernicious anemia, the rule of thumb is actually to still continue as giving IM, B12 supplementation, more so because it is just an injection that you can give every month or so to help to maintain them. But there are some patients who do get by with high doses of oral B12, because even without the intrinsic factor, if you just go by diffusion, they can absorb roughly about 1% of whatever oral B12 that they consume. It is not unreasonable to give them high doses of supratherapeutic B12 in that instance, but definitely not at the beginning when they're anemic and we are trying to replace their stores.
Okay. So at the beginning, you would probably give like 3 doses of IM-B12, then subsequently, how frequently do you give the IM injections until they are replete?
So I have another slide on that actually. So it depends on what kind of a B12 formulation that you're actually using. So for this, the UK or what up to date sometimes quote, I haven't checked up to date recently, but normally the British actually uses hydroxycobalamin, which is 1,000 units 3 times a week for 2 weeks, or some people give it for 3 days and then that's it. And then after you do it once every 3 months for maintenance. But in Singapore, we only have the cyanocobalamin. And that is actually IM or subcutaneous dose daily for 7 days, and then once a week for 1 month, and then monthly for maintenance. That's what we do. And polyclinic actually can give this to our patients. So if a patient has pernicious anemia with no gastric CA, etc., we actually do discharge them to the polyclinic for just monthly maintenance dose of the B12. Yeah, that's what we do.
What about endoscopic evaluation for pernicious anemia?
So I took this from the British Society of Gastroenterology, Joanne. Yeah. So essentially, we only refer off to the gastroenterologist if they are usually more than 50 years old with laboratory evidence of pernicious anemia. But this evidence is actually quite low grade. A lot of the times we actually go by their symptoms as well. If a patient is like 40 or 30 but has gastric symptoms in addition to pernicious anemia, we refer them anyway because we never know in that sense. Maybe would like Kelvin like to comment on this?
The association of gastric cancer and pernicious anemia is an interesting one. I think a lot of the older studies, meaning the 30, 40-year-olds, well, 30-plus-year-old studies, actually showed there to be a reasonably strong association. But the more recent studies and presumably the larger, more so-called more accurate studies have not been able to show this association. So that said, so I agree. I mean, probably our baseline cancer risk is not that low. We are certainly a bit higher than the British in terms of the gastric cancer risk. So I would have a lower threshold basically for considering. So maybe in our population generally above 40, we think there's probably some role to at least have a check or at least evaluation. It's not cast in stone. There's no recommendations, guidelines, or anything that you will find to support that. But it's just probably just being a bit kiasu, I guess.
Okay, thank you. Okay, maybe a quick one on folate deficiency.
Yeah, so folate deficiency wise, I mean, the problem is that your serum folate, which is what comes in your B12 folate panel, actually fluctuates a lot with daily intake. And there is no clear consensus actually on the level of serum folate that indicates deficiency in that sense because of such great fluctuations. But conventionally, people have quoted that the serum folate lower than 7 nm per liter actually suggests that of folate deficiency. It's not really common to be folate deficient because folate comes in a lot of our food. A lot of the cases, the patients who are folate deficient are usually those who have like high turnover. For example, patients who have hemolytic anemia, patients who are chronically hemolyzing for whatever reason. Usually those are the patients who tend to have folate deficiency, but otherwise it's quite rare.
Okay. So yeah, hemolysis, as you had just mentioned. I think we probably don't have time to go into great detail, but maybe some questions. So sometimes people will say send off the hemolysis screen, sending everything LFT, LDH, hepto, peripheral blood film. Which ones are of higher sensitivity or specificity? For example, oftentimes patients have a baseline LFT. If that's normal, should we still be considering hemolysis? And maybe you could just take us through just a brief overview of the workup and some of the specific tests like hepto.
Okay, so basically for hemolysis, maybe we'll skip this, is basically talking about what are the different types of hemolysis, and this is the workup for autoimmune hemolytic anemia. So essentially, I think the question is, with a normal liver function test, does it exclude hemolysis? Maybe that's what you're asking in that sense. So it actually doesn't exclude hemolysis, because you could still have low-grade hemolysis in the background with no LDH rise, with no unconjugated hyperbilirubinemia. It is still possible. So it depends on what your clinical suspicion is at that point in time. But having said that, if you are very suspicious and you are still worried about hemolysis despite having a normal LFT, then you probably want to do things like a DCT, for example, at least a peripheral blood film. We can look for spherocytes that might suggest, or schistocytes, etc., that might suggest what kind of hemolysis it is. So a haptoglobulin is useful in hemolysis, but it's also lowered in a lot of other causes. For example, liver dysfunction is probably one of the most common causes for having a low haptoglobulin. And it's so sensitive that any amount of hemolysis would actually cause it to be lowered. So having a normal haptoglobulin helps you to exclude hemolysis, but having a low haptoglobulin does not confirm the presence of hemolysis in that sense.
Okay, got it. Maybe just a very, very quick word on the causes of hemolysis and how we should approach it. So I mean, in medical school, we are taught different frameworks, right? So first and foremost, whether it's immune or non-immune mediated. So perhaps for the immune mediated bits, right, does the concept of whether it's like cold agglutination, warm agglutination, something that is clinically significant, or is it only from the pathophysiological point of view and it doesn't really affect how you work patients up?
So cold versus warm actually helps to make a lot of difference in terms of how we work him up. Because, for example, a cold autoimmune hemolytic anemia is more often associated with lymphoproliferative disorder as compared to a warm IHA. But that doesn't mean that it is mutually exclusive, meaning that if you have warm IHA, you can't have a lymphoproliferative disorder. It doesn't work that way, but it's just that it's more associated with it. In terms of the treatment also, it makes a great difference. For example, warm IHAs respond better to things like splenectomy, things like rituximab along those lines, and steroids, whereas cold IHA doesn't really respond so well to all of these other treatments. And cold IHA, a lot of the times, not so much can be done, although you can try. And in the cases of cold IHA, it is due to an underlying lymphoproliferative disorder that you might need to treat that before it comes under control in that sense. In terms of blood products also, it makes a lot of difference. So in cold IHA, if you warm up the blood, technically sometimes you can do all of these testing in the laboratory without having to do too much further investigations. But for warm IHA, it's usually quite difficult not to do in that sense. Yeah.
Okay. And the last question, in general, are patients with autoimmune hemolytic anemia transfusion responsive? Should we be, because of the concern that there can be antibodies that respond to the transfused cells?
So I think it depends. If your patient is compensated, it means your hemoglobin has been about 8 and it's not dropping, for example. So the rate at which you're hemolyzing is equal to the rate at which you're producing, then that's fine. Don't transfuse them. But if your hemoglobin is 5 or 6, your patient is actively hemolyzing and cannot compensate in time for whatever reason, then actually you should transfuse them to help them, to prevent them from having symptoms of anemia or getting complications of anemia. But having them chronically transfused is not the right answer in that sense. Having them chronically transfused will just introduce them to a lot more antigens and make them develop more antibodies. So in summary, to answer your question, I think in the acute setting, it is completely reasonable and should be done if your patient is having symptoms and anemic and cannot compensate in time. But the treatment for in the chronic setting, in that sense, after the acute incident is over, should be to immunosuppress or treat the underlying cause of the IHA, as opposed to giving them chronic transfusions.
Okay, thank you. Okay, so thanks so much for your time, everyone. Maybe we could just go one round from different point of views to maybe just highlight some take-home points for the residents. Maybe Sanmay, you can start from the renal point of view.
Okay, so from my point of view, I think if you approach anemia and CKD patient, you should still do it as per the general evaluation for a normal patient. And then from there on, you just need to be aware that the thresholds for iron deficiency is different for your CKD cohort than from your non-CKD population, and start your therapy based on that.
Dr. Koh?
Yeah, I think from me, I think basically just treat the iron deficiency with respect as a marker. Potentially, it could be malignant disease, peptic ulcer disease, and all that. So the bottom line is to basically evaluate the patient, take a history, what the most likely probabilities are, and then work from there. So to basically work through with the patient, what is the most likely etiologies and what are investigations that would confirm or rule out etiologies, including endoscopy.
And Joan, any last words you have for us?
I think Sanmay and Kelvin have covered most of it, but essentially, yeah, it's the same. Nutritional-wise, iron deficiency and B12 deficiency. Sometimes it's just a symptom of whatever's underlying it, and you need to go and look and cure for whatever is beneath it, and maybe giving them just giving them supplements would not. It won't solve the problem in that sense. Yeah.
Okay. Thank you very much. So I think it's been a very helpful hearing from the different points of view. So thanks so much for your time today.